Classical primary sites include breast, lungs, prostate, kidney, and thyroid. Vertebral column is the most common site of skeletal metastasis. 10% of metastatic disease will develop spine metastasis, and 1/3 will become symptomatic. Causes of neurological deficits include mechanical compression, direct compression of tumor, compression due to vertebral cord body collapse, vascular incompetence, ischemia due to arterial embolism, venous congestion, kyphotic deformity, spinal malalignment. And among these, we know that the optimal clinical management of these patients require integral decision by an interdisciplinary cancer team. Medical and radiation oncologists are a big part of that. Spine surgeons play a huge role, and there are other healthcare professionals, including rehab people, physiotherapists, nursing, and other medical specialists. NICE and evidence-based guidelines are available. Spinal Metastasis by Dutch National Working Group on Neuro-Oncology plays a huge role. We generally use a CT, MRI, FDG, PET, depending on what we need, and that's the minimum workup that we need. Decision making is tough. Urgency to prevent paralysis. On the other hand, is potential of post-surgical morbidity in weak patient with limited life expectancy. Dilemma in decision making is because many factors are involved. It's kind of tumor load like this, life expectancy, exact pathology. Pathology plays a huge role. Functional status of the patient, neurology of the patient, age, the comorbidities associated, the quality of the bone, instability associated with causing pain, the progression of the disease itself, and the treatment options available. So on one side, you could have a patient who's alive and well, and on the other side, that patient could be alive and miserable. So if the outcome is less than 6 months, sometimes we think about, when considering all the factors, that maybe no surgery may be warranted in these patients. So prognostic factors, functional status, number of visual metastasis, primary tumor pathology, age. So for example, if I have a patient who has I'm just going to go back on that, who has a 60-year-old with back pain, sciatica, diffuse lung disease with the liver and bone metastasis, and their scores were like Tokashi of 4, Tomita of 10, modified Bohr of 1, and Sims of 14. Survival makes it less than 6 months, and then obviously you think about managing these conservatively. The whole thing changed in 2005 when Peschel came out with this paper in Lancet in August of that year and showed that direct decompressive surgery plus post-operative radiotherapy was way superior to treatment with radiotherapy alone for patients with spinal cord compression caused by metastatic cancer. And what they showed was that Kaplan-Meier estimates of length of time all study patients remained ambulatory after treatment. The game changer was this, that patients who had surgery and radiotherapy had much better ambulation and survival in these patients. So the trial was stopped early at interim point because the differences were quite drastic between the two groups. The patient undergoing surgery was significantly better in terms of ability to ambulate and survival. So if you look at solid tumor with high-grade epidural spinal cord compression, surgery 84% were ambulated versus 57% of radiation. The duration after surgery, their survival was way up, and it was 120 days versus 13 days. Ambulation 62% versus 19%, and continence, as you can see, 155 days versus 17 days. So continence, less narcotic requirement was a huge role in this trial. So survival analysis depends on short-term survival, age, Karnofsky's performance score, and long-term depends on patient's pathology and the vertebral levels involved. And so this study in 2016 was about, can we avoid inappropriate patient selection? So patient selection is very important in these group of diseases. So options for therapy are systemic therapy, chemo, immuno, hormonal therapy, radiation therapy of different kind, and now more and more of radiosurgery. Then the surgery is percutaneous cement augmentation, percutaneous fixation, anterior posterior in block resection, or separation therapy. The NORMS framework, which came out in 2013 by Loffer, showed that a score was devised, and aim was to simplify a treatment decision for metastatic cervical tumors. It was based on neurology, oncology, mechanical instability, and systemic diseases. So, for example, if a patient like this had metastatic tumor outcomes for neurology, we look at how much of compression there was, what kind of neurology was that in patient, what was the histology, instability, and mechanical disease, and we decide what exactly we're going to do. Also, at that time, we knew that there were some unfavorable tumors to our radiotherapy, and that outcome was bad, although this has changed since this was published, and now we have got majority of these tumors now come into favorable outcome with high-dose radiosurgery. Bilski published this epidural spinal cord compression scale, in which they divided into three main groups. The first group was tumor extension into the epidural space with deformation of spinal cord with epidural impingement, say as 1A, and 1B was deformation of thecal sac without spinal cord abutment, and 1C was when the spinal cord was abutted without compression. 2 was CSF compression, CSF was still visible, spinal cord compression without visibility of CSF was 3. And depending on that, we used to make decision on how we're going to treat these patients. A patient who had a high-grade epidural spinal cord compression generally required surgery versus a smaller compression did not. On the other hand, it also depended on how radiosensitive or how radioresistant that patient is, or what was the role of treatment previously in these patients. So radiosensitive tumor, somebody like this, multiple myeloma, given radiation on 22nd of July, and you can see their outcome is completely disappearing, and they're amazing results. So neurological assessment is critical. External beam high-dose radiation, but the safe delivery of SRS requires 2 to 3 millimeter margin on the spinal cord in order to avoid radiation myelitis. Most commonly, SRS uses restricted tumors confined to bone or to minimal epidural impingement. So this was way back in 2010. Then came radiation surgery, which changed the way we do things with metastatic spine, and we used to decompress the spinal cord in order to reconstitute the spinal fluid space in conjugation with long screw rod construct and instrumentation. So cumulative incidence of recurrence was only 16% in these patients in a year's time. This decompression provided a safe margin to deliver a cytotoxic radiation dose to the tumor within the constraint of spinal cord tolerance. So 1 year failure risk of only 6.3% when the radiation dose was high up to 18 to 24 gray. So something like this, so we separated this tumor from the spinal cord and then gave radiation, and we did MI surgery in this patient. Some of these patients had in the start, for example, this liposarcoma had open surgery and then had radiotherapy to follow that. So metastatic tumor assessment, obviously again, neurological, myelopathy, functional, oncology depending on pathology, and then mechanical instability. So mechanical instability, we looked at with the SIN score, which was again a brainchild of the spine oncology study group, and they published this in 2010 and 11, and integrates systemic literature review with expert opinion. So SINs included the components depending on the location. It was junctional, mobile, semi-rigid or rigid, pain was present or not, alignment, vertebral body more than 50% collapse, less than 50% collapse, and no collapse, and posterior lateral involvement. In patients who had a score of 0 to 6 was potentially were stable, 7 to 12 were potentially unstable, and 13 to 18 were unstable and required surgery. So, for example, a patient like that, breast cancer, bilateral mastectomy, chemo, neck pain, no other metastasis. So their score was location was 1, pain was 0. So if you see overall score of 6, stable and do not require any intervention. So SINs of 155 patients, and they showed that 16 patients experienced complete response and 65 a partial response. So lower SIN scores indicate stability. So, for example, a patient like this who had unstable spine, and if you see their scores are up to 14, and then obviously this patient required surgery. Percutaneous posterior fixation has also played a huge role, because then we can give radiation straight away or early, and that's all is possible with good outcome. So we did this, we published this in Surgically Spinal Metastasis. Two prognosis scores have a role, and with 63 patients, we analyzed and we came up with different scores, and we looked at them with Tomita, revised Tokuhashi, and eventually modified Bohr and SIMS. And we came up with this, that Tomita score had the highest statistical significance to predict scores. SIMS was a predictor of instability but not survival. And individual factors in our group study was age, preoperative neurology, vertebral levels, metastatic levels, and KPS. So Tomita score provided the highest statistical significance, followed by Bohr. So in conclusion, what we said was that norms integrated modern radiation and surgical options, SIMS addressed instability, modified Bohr better predictably due to unanimous application of the score, and separation surgery followed by SRS provided durable tumor control without the need for extensive tumor resection. We did another study looking at the disease versus the individual level, and we found that the disease level was more important than the individual person's issues. Risk factors for pathological fractures and metastatic epidural compression, patients with spinal metastasis, pain, tumor size with the vertebral body, vertebral end plate and 3-column involvement, primary tumor growth rate, and multiple vertebral metastases associated with increased risk of pathological fractures. So patients with osteolytic metastatic lesions causing pain greater than 25% occupancy of vertebral body, and involvement of end plate and 3 columns should be considered for prophylactic or decompressive stabilization. So if we look at over the years, some of the results of treatment of various kinds, radiotherapy alone gives 27% survival. The results were laminectomy and with or without radiotherapy, 28%. Then we had radiation, posterior decompression and stabilization, 55%. And then vertebral body resection and destabilizing, 62%. And now spinal cord decompression, followed by stereotactic radiosurgery. The results are going better and better, and up to 88%. So the SOSG strong recommendation is made that patients with high-grade spinal cord compression due to solid tumors should undergo surgical decompression and stabilization followed by radiotherapy. Neurological and functional outcomes, pain control, complications thoroughly documented for surgery he played a huge role. So from the norms perspective, surgery is reserved for patients with radio-resistant tumors who have high-grade spinal cord compression. It's used to preserve or restore neurological function, stabilize. Mechanical instability is an indication for surgical stabilization regardless of tumor sensitivity or histology. So stereotactic radiosurgery has revolutionized the way we deal with these patients. Currently, the major surgical indication is mechanical instability and high-grade spinal cord compression. And surgical trends include less invasive surgery with emphasis on durable, local control, and surgical stabilization. Now, recently, LMNOP framework has come into play a lot more, and two additional key considerations in this are location and spine levels of diseases and responses to previous therapy, and it includes level of disease, mechanical instability, neurology, oncology, patient's fitness, prognosis, and response to prior therapy. So nowadays, if a patient comes in and if you look at the global performance status, if the status is poor, then consider best supportive therapy. If the status is good, then we can, depending on systemic burden of the disease, can decide how extensive we want to be treating these patients, or are we going to be using minimum treatment options. If we have unstable and stable, so if it's unstable, you go towards surgery. It's stable depending on how much the load there is, how much are the radio-resistant or radio-sensitive, and the patient's outcome is favorable, unfavorable, decide what exactly and how we're going to treat these patients. Dear friends, in conclusion, spinal metastasis requires a multidisciplinary, multidimensional treatment. With the onset of stereotactic radiosurgery and concept of separation surgery, the assisted role of radiotherapy and surgery together have shown significant better results. SRS has eliminated the concept of radio-resistant tumors now. No specific algorithm, but LMNOP is widely used as it incorporates both the previous treatment options, utilize current condition, primary etiology, and disease spread. And It's really my pleasure to be taking part in this amazing webinar, and I wish you all the best. I welcome you to the interim meeting of World Spinal Column Society in November of next year, and you're welcome to Pakistan anytime and to enjoy beautiful northern areas. So it's a pleasure being with you. Thank you.